Stop. Perfect.
Can you see and can you hear?
I can see and I can hear.
Lovely.
So,
all right then.
To introduce you formally, this is Julie Goodfellow. She's a specialist nurse for inherited cardiac conditions based at the Freeman Hospital, and she's going to take you through inherited arrhythmia. Thank you, Julie.
Thank you. Hello, everybody. Happy New Year. So as Kay says, I'm Julie Goodfellow. I've met some of you probably. I had a quick whiz through the names, and some of you we've not met in the past. I'm going to do a bit of a whistle-stop tour through. I've been asked to do inherited arrhythmia, but I decided it was probably more like arrhythmias due to inherited cardiac conditions. I'm not going to go in depth in all of the arrhythmias because I'm sure Neil Seller will be doing that. It's more a case of what conditions are inherited or potentially and can cause arrhythmias, and I'll skip through some of it, and others we can concentrate on if you ask me questions. So inherited cardiac conditions are probably commoner than you think. Now, these figures are a bit old, and I found it incredibly difficult to find any more up-to-date ones because they're all over the literature, but they seem to have the same source from a very long time ago, and they haven't been updated. I suspect some of them are a bit out of date by now. You'll have heard of all of these conditions, I am sure. Hypertrophic dilated cardiomyopathy is the bulk of the work that I was doing before about 5 or 6 years ago. And then I got much more involved with the inherited arrhythmias, long QT syndrome, Brugada syndrome, CPVT, arrhythmogenic right ventricular cardiomyopathy, which obviously belongs with the cardiomyopathies, but very often causes the arrhythmias rather than typical cardiomyopathy problems. And then you've got the inherited cardiac conditions like familial hypercholesterolemia, Marfan syndrome, progressive cardiac conduction defect. I've got that down as an estimated prevalence of rare because I couldn't find a figure for it. Maybe Neil might be able to help us with that when we get to that stage. The majority of these are always genetic. They're always inherited. They're caused by a genetic alteration or a gene mutation, which is pathogenic. So why do I do the job that I do, which is largely carrying out family screening and working with people who have inherited or possible inherited cardiac conditions? There's been a growing awareness over the past decade and a half, probably, that inherited cardiac conditions are something that we should be dealing with. Back in 2008, the National Service Framework Coronary Heart Disease added a chapter as an afterthought on arrhythmias and sudden cardiac death. And it was noted that people die from inherited cardiac conditions unnecessarily. Most of the inherited cardiac conditions are inherited in an autosomal dominant fashion, and therefore 50% of first-degree relatives are at risk. We know that lives can be saved through screening these at-risk individuals, and I could give you anecdotal and hard evidence that that is the case. So the Cardiac Family History Service and nurses like me and inherited cardiac condition teams around the country evaluate families who could have an inherited cardiac condition, and they do that on the back of this chapter 8, which said that these patients and families should be seen in a dedicated clinic. They should be seen by staff who are trained in the management and diagnosis of inherited cardiac conditions, and they should be given appropriate support, genetic counselling and testing if appropriate. Around half of cardiomyopathies are inherited. ARVC is inherited. I think probably the half of the cardiomyopathies is probably a little bit low anecdotally, but I haven't got the hard evidence to prove it. I think that more than half of them are inherited. Channelopathies, your inherited arrhythmias, are always inherited. Early detection, particularly with the cardiomyopathies, can decrease the severity of the illness and increase treatment choices available. Certainly decreases uncertainty for people. They know what they're dealing with, both professionals and patients and families, and it helps the families to have some control. It also gives us an opportunity to educate them and support them. Cardiac Family History Service was set up on the back of Chapter 8 in 2009, and this just shows the map. We basically cover the whole of the northeast region and over in North Cumbria. So anywhere from the borders down to the south of Teesside and even into North Yorkshire and right across as far as Whitehaven. There are 3 cardiac genetics nurses. I'm one of the original ones. My title has now changed a little bit because I've moved from being employed by Sunderland to Newcastle. Cardiac genetics nurses, I think that's quite an accurate description of me. It's basically a Sherlock Holmes type person, if you like. We're clinical detectives, and we work to support and investigate families who have suspected inherited cardiac disease so that we can then access genetic testing to try and give them more support and more answers. We provide counselling, information, we draw up scientific pedigrees, which are family trees. For those of you who don't know, we organise and carry out family investigations. We organise cardiac tests, echoes, ECGs, exercise tests, etc. And then we discuss the results with the patients and advise them about the implications. It's really important when we're dealing with these families to phenotype them. So what I mean by that is to find out exactly how they're being affected clinically and physically, so that we can add that information in when we're trying to interpret any genotype or the genetics at a later point. We work out the probability within a family that they have inherited cardiac disease, and we do this largely with cardiomyopathy families, inherited arrhythmias, and we also work with sudden cardiac death families. Sadly, some of you will know this, you'll have come across it. Sometimes sudden cardiac death is the first symptom that there is an ICC within a family. Just a little bit of background, you can see that this is a cumulative graph. You used to seeing these from Boris's and scientific meetings recently. It's basically just a cumulative graph of referrals to the Cardiac Family History Service since we started in 2009 to 2020. And I'm just showing you this just to show that I think there's definitely a link between awareness and the time put into increasing awareness and the referrals that we get. And I know that because this green line was Sunderland, where we had a full-time nurse at the beginning who then left at about 2015 to 2016. So she started off with great gusto and we got lots and lots of referrals. Freeman, which is the red line, and James Cook Hospital, which is the blue line, took a bit of a time to get off the ground. But then you can see that they've steadily risen. In 2016, I started to put a bit more effort into trying to raise awareness. And then in 2018, I secured full-time hours, and you can see that the graph gets a bit steeper right up until 2020. And I haven't got any more figures on beyond that, but you can see we all flatten off, and you know the reason for that. Types of referrals that we see at the nurse-led cardiac genetics clinics are largely, as you can see, about 75% cardiomyopathies. This graph shows the number of probands. Those of you who don't know, a proband is an index case, somebody who has an inherited or a possible inherited cardiac condition. And then they're referred in, and we see them as the index case within the family. And the red lines, the red blocks, are the consultans and cascade patients. A consultant is an index case, but somebody who doesn't necessarily have the condition, but has come along because of a family history of the condition, and they're the first person in the family we know about them. And the cascade referrals, they're people who are first degree relatives who have been invited along for screening on the basis of seeing the consultant or the proband. Technical terms that don't really matter too much, but you might come across them. You can see that hypertrophic and dilated cardiomyopathy are the big referrals. This is at Freeman Hospital. It's interesting that if we did this for Sunderland Royal and for James Cook Hospital at Middlesbrough, there would be more hypertrophic cardiomyopathy families than dilated cardiomyopathy families. And I suspect that's because of the nature of the work at Freeman and the Heart Failure Specialist Centre and the transplant families. And then we have the out-of-hospital VF arrests who've survived, and then you have the inherited arrhythmias, long QT, Brugada, generalised arrhythmias, and then we get a smattering of Marfan's, MI, bicuspid aortic valve. It's interesting to see the sudden cardiac death in 2019 alone, just at Freeman, and I suspect we didn't get all of them in the area. There were over 20 sudden cardiac death families that were referred just to Freeman that year. Sudden cardiac deaths are obviously caused by a fatal arrhythmia. Generally, the term means anybody who's died suddenly and there's a cardiac reason. So if we look at the figures overall, there are 100,000 or so sudden cardiac deaths in the UK every year. Most of them are due to coronary heart disease, so it's wear and tear, lifestyle, high cholesterol, smoking, all the things we know about. Of those, there are about 500 deaths that are unexplained. That means that at post-mortem, there's no evidence of ischemic heart disease, there's no evidence of structural heart disease, toxicology is normal, and they're put down to sudden arrhythmic death syndrome. Most of these affect young adults and teenagers. And the important point here for you coming across these families is that up to 50% of their relatives are at risk of sudden cardiac death. Sudden cardiac death in the young. When we first started this service, we have some regional guidelines called Cardigen guidelines, and in there it defines anybody young as less than 40. That puts me way out of that league, and I wouldn't be a sudden cardiac death in the young if I was to drop down dead, which is very sad. We're a bit more fluid about that these days. Anybody in the family who dies probably below the age of 50, certainly we're going to investigate to see whether or not there's a reason for it or whether it could be an arrhythmic death. There are about 50 of these sudden cardiac deaths in the region annually. Some of them, when they're investigated, are found to be due to ischemic heart disease, due to a familial high cholesterol, familial hypercholesterolemia, and there are very specific guidelines on how to diagnose that. We actually have a regional service of familial hypercholesterolemia nurses who work out at the Centre for Life in Newcastle, and they will see these families and do genetic testing and do cascade predictive testing. It's a very treatable disease and people should not be dying from that in 2021. Some of these deaths are down to aortic dissection, either due to connective tissue disorder or familial thoracic aortic aneurysm. Many of them are due to heart muscle disorders, the cardiomyopathies I've mentioned, and the rest are SADs, sudden arrhythmic death due to inherited arrhythmias such as Brugada syndrome, non-QT syndrome, CPVT, and progressive cardiac conduction disease. I'm going to skip through these, seeing who's on the call. You all know what these conditions are. I borrowed the slides from a previous presentation because I didn't know who would be on the presentation today. I think the main points that are pertinent to this presentation are that these cardiomyopathies can cause arrhythmias. You know that. They can cause sudden death, they can cause syncope, palpitations, as well as heart failure symptoms. With dilated cardiomyopathy, sometimes before the heart dilates, before there's any structural damage, we often see atrial arrhythmias, a lot of PVCs, VEs, non-sustained VT, and heart blocks. Arrhythmogenic right ventricular cardiomyopathy, that might warrant a little bit more thought. It's inherited. It is caused by a set of genes which are involved in the desmosome of the cells. So arrhythmogenic right ventricular cardiomyopathy occurs when you get fibrofatty replacement of some of the myocardial cells, and it affects the structures that keep the cardiac cells together, and it can affect the electrical conduction system, and it will cause arrhythmias. It's difficult to diagnose. There are an international set of diagnostic criteria. Certainly the medics in the audience, I'm sure, will know of them. There are minor and major criteria. The differences can be subtle, and I have sat in MDT meetings where there's been quite a lot of discussion amongst people who see this quite a lot as to whether this is ARVC or something else. There are 4 phases. If you look at the literature, there's a concealed phase. So younger people, certainly people that you'll come across if you're largely paediatric trained, or people who might not have any structural damage there, but they are at risk of sudden death during exertion because of hidden problems with the electrical conduction system. You then get overt structural changes to the muscle that can be seen on MRI, and that can cause, they can be at risk of death at that stage as well. They might have palpitations, they might have syncope. And then we get the next stage, which is weakening of the right ventricular wall, where it becomes stretched, the pump becomes weaker. You start seeing arrhythmias, but also signs of heart failure. This is an awful slide. You're not meant to read it. It's just for those of you who aren't familiar with it. This is a copy of the 2010 revised task force criteria for diagnosis of ARVC. And it's really just meant to tell you that it's complicated. There are imaging, family history, and depolarization and repolarization changes to look at, as well as pathology, histopathology, in order to diagnose it. Can you hear me? I'm getting a lot of feedback all of a sudden, and I don't know why I've not changed anything at this end, Kay. Hello? Hello? Kay?
It does seem to have gone away there, Julie.
It's gone, has it?
Yeah.
Okay, lovely. Thank you. It just came from nowhere, and I haven't done anything different. Thank you. Okay, can you all hear me again?
Yes, you're fine.
Thank you, that's great. Okay, so just moving on to the electrical conditions, long QT syndrome. I'm sure that most of you will have come across that. It's an ion channelopathy, which largely affects the repolarization of cells. Quite common. It says it's rare in the literature, but 1 in 5,000 people is quite a lot of people. I also see an awful lot of these families, so I guess I've got a bit of a skewed view of how common this is. It's caused by a pathogenic gene variant, which affects the ion channels in cardiac cells, usually the potassium channels and the sodium channels. There are lots of different types of it, but there are 3 that are particularly common, 1, 2, and 3. Ion channels, for those of you who aren't medical or perhaps haven't got any physiology and anatomy, ion channels are the routes that the ions take in and out of the heart muscle cells that regulate the electrical charge of cells and cause conduction of electricity through the heart, and that regulates the heartbeat. If these channels don't behave properly, don't behave normally, then the electrical function becomes abnormal and people are prone to arrhythmias, usually ventricular arrhythmias, which can cause people to collapse. Symptoms are either no symptom, people can have blackouts, they can have palpitations. Sometimes, and I think probably with children this might be the case, children suffer from seizures. And quite often people have been put on anti-epileptic medication for years by the time I come across them. Hasn't really helped, they're still having seizures, and this is secondary to lack of oxygen to the brain. And sometimes, sadly, sudden death is the first symptom of long QT syndrome within a family. Long QT, for those of you who don't know, is basically a measurement. The QT interval is a measurement on the ECG. So it's a measurement that goes from the beginning of the Q wave to the end of the T wave. It's quite difficult to measure unless you're doing it all the time. There are a lot of guidance out there on how you can do it. Once you've got that measurement, you have to realise that that measurement will change with heart rate. So the faster the heart rate, the shorter that will be, and the slower the heart rate, the longer that will be. So you have to correct it in order to know whether it's abnormal for the heart rate. And there are various formulas out there. One that seems to be in the literature most is Bazet's formula, or Bazet's formula, depending on how you want to pronounce it. And that is a product of the QT interval in seconds divided by the square root of the cardiac cycle in seconds. Cardiac cycle you can measure by looking at the R wave to the next R wave, which is on this diagram. Your machines, your ECG machines will probably do it for you, but sometimes they're not completely accurate. And this should be done by somebody who is used to doing it. So if there's an abnormal measurement that's being flagged up by your ECG machine, get somebody else to have a look at it for you if you're not certain yourself. Tolerances do vary, and it depends on whether they go with symptoms or not, but generally if you're doing a 12-lead ECG, your QTC is being shown as over 440 milliseconds in male and 460 in female. We might think, oh, okay, that's a little bit longer than it should be, and have a bit more think about it. When you look at the literature, I got these diagrams of life in the fast lane. It will show you ECGs that are fairly typical for the different types of long QT. Long QT1 and long QT2 are due to abnormalities in the potassium ion channels, and long QT3 due to an abnormality in the sodium channels. I didn't think these were particularly brilliant. Long QT1, you get a long interval, which looks to me like a fairly normal ST segment and T wave, which is just elongated over a longer period of time. Long QT2, you get these long ST segments, which sometimes have a bit of a hump back on, like a saddleback on them, and you can see there's a little lump on there, but they're not particularly brilliant, I'm afraid, on this one. And long QT3, you get this long isoelectric line before the T wave after the QRS complex. Not always very obvious, but I thought it was worth showing you that. As well as knowing that this is long, we have to do something about it, obviously, and we do that because we want to reduce the risk. I normally give advice to people about lifestyle and about how to manage it. It's not my job to prescribe. I'm not a nurse prescriber, but I work alongside the consultant cardiologist who will prescribe. The advice I will give to people is that if they have type 1, if we know it's type 1 and it's been genetically proved, we give them caution about exercise and swimming, because very often people will have arrhythmias during exercise and typically through swimming. Sometimes I'll ask families about, are there any drownings in the family? Because that's something, family folklore often gives you quite a lot of background information when you're talking to people about the families, about whether or not somebody else might have died in the family or had problems, when you're trying to work out how many people have been affected by this. Type 2 is sometimes associated with loud noises, sudden arousal, startle. I knew of a family when I first started doing this where sadly 2 people died and they were type 2 long QT. It wasn't picked up after the first death, which happened when somebody was having an argument with a neighbour actually, and the neighbour went indoors, banged the door very loudly, and that person collapsed and actually died, which was really sad. And then about 4 or 5 years later, her niece was getting up very early on Boxing Day to go off to a pub where she was working to set up ready for lunches. Her alarm went off in bed and she had an arrhythmia, started making very strange noises. The family came rushing in, but unfortunately they couldn't save her. That was really awful. And when you hear these stories, you kind of think, could that be real? But it is, sadly. And the sorts of things that if we see long QT on ECGs, I think we should be asking about the family history, because it might mean that there's a bit more to it than meets the eye. Type 3 long QT syndrome, very often, but not always, people will die in their sleep or will die at rest. So we give some general lifestyle advice about that type of thing. We also give advice about avoiding medications. There are certain medications which will affect the conduction of electricity to cardiac cells, and sometimes will lengthen the QT interval that's already long and put it in a more dangerous point. So we tell people to avoid any medications that aren't prescribed, and any new prescriptions should be discussed with the medical practitioner, who can check out whether or not they're going to affect the QT interval. I used to give a list of medicines to people on paper, and nowadays what I do is I signpost them to crediblemeds.org, and that site is really good. If you go on that, you can download an app onto your smartphone and you can just type in any medication. It's really handy to have when you're in clinic, I think, to check whether or not something you're prescribing for somebody who's got a long QT interval is safe. We tell people to avoid excessive alcohol and recreational drugs because they can have an effect on the conduction in the heart. Excessive alcohol can cause dehydration, it can cause skewing of the blood chemistry, and that can make it more likely that you could have problems with arrhythmia. We talk about safe rehydration. So if people have GI disturbances, so they've got the squits out one end and they're being sick up at the top and they're not keeping any fluids down, obviously they're going to become dehydrated. But instead of just replacing the fluid with water, we talk about rehydration salts such as diarrhea. I always tell them there's cheaper versions available, keep them in the bathroom cabinet, because it's important to safely rehydrate to try and keep the blood chemistry as normal as possible to reduce the risk of arrhythmia. Beta blockers are really good at reducing the risk of arrhythmia in people with long QT. syndrome. They won't necessarily shorten the QT interval, but they will reduce the excitability of the heart, I guess, and make it less likely that people will have an arrhythmia. Nadolol seems to be the cardiologist's drug of choice, but quite often people will have bisoprolol as well. You have to be cautious with type 3, because type 3, if you remember, is associated with the sodium channel, and people very often have problems with arrhythmia when the heart rate drops down very low, and therefore that's why we see it more during sleep. Sometimes what you have to do if people are having a lot of arrhythmias with type 3 is you have to beta block them, and then you have to pace them. So devices are used in the management of long QT syndrome for both primary and secondary prevention, and that's permanent pacemakers and ICDs. Genetic testing is always warranted. If we can identify a genetic variant in a gene which codes for these ion channels, then we have a definite genetic diagnosis. We can use that to predictively test other family members and hopefully save lives. This is a typical torsade de pointe. If you haven't seen this before, it's a kind of a twisting of the ECG. And this isn't always what we see in long QT, but it's fairly typical. It can start spontaneously. I think it's with an R on T probably, and then it can stop spontaneously, or it can deteriorate into VF. This is a family that I've come across in the last few years. The lady in the middle here, FM, was my proband, and she was referred by one of the adult cardiologists at Freeman to the Cardiac Family History Service clinic with a prolonged QT interval, probably long QT syndrome. When she came to the clinic, she told me, we drew up a family tree, and she told me that she'd sadly lost her dad the year before. Her dad had died suddenly in his 60th birthday. She said it was so sad. They had a really thoroughly day. He was thinking about retirement. He'd had a big party and he'd drunk lots and lots of alcohol. He went to bed and he never got back up again. At the time, we took bloods and consent and we sent off for genetic testing, and I advised her that her first degree relatives should undergo clinical screening while we waited for gene testing to come back. I suggested that her children got screened, and I suggested that her sister and brother, who were twins, got screened, and she had a half brother through her mum who had a different dad. But we also suggested at that stage that he got screened because we didn't know what was going on in this family. Nobody came forward for clinical screening. Chased her up and she went, yeah, I've told them about it, but nobody's bothered. And then a few months later, I think it was a couple of years later actually, little girl down here, RN, she appeared on Ward 23 at the Freeman under Dr. Seller, and I was asked to go along and talk to her mum. She'd been swimming and she'd had a collapse. I've written cardiac arrest there, but I think actually collapse is probably better. And she'd recovered and she'd come into hospital, and it was found that she had a very long QT interval, or I forget what it was, but it was quite long. I spoke to mum and dad, and as I spoke to them, this story became very familiar. She started to tell me that her sister had a long QT and that she'd lost her dad a couple of years before he died on his 60th birthday. So I went back and dug out the family pedigree and started adding people to it and realised that this was the same family. Because of that, we were able to go back to this lady, the proband. We'd found a gene mutation, so we were able to then test this little girl's mum, who also had it. The little girl had it, and then we were able to test her siblings, her uncle, her cousins, and all of these people with a little colouring in there, a little mark, they've all got this gene mutation. So they're all seeing a cardiologist, prescribed beta blockers to try and reduce the risk. We weren't able to test dad, so we tested mum instead, so this little girl's grandma, and she was negative. So that put half brother and all of this side of the family on the left in the clear, and then we were able to start testing the siblings of the dad. This one here, I never did find the result actually. They lived away, so I must chase that one up. This lady was negative and this one was positive, so her children, who I haven't got marked in this pedigree, would go on and have testing. So that's why we do what we do, because through that, hopefully, we'll save other cardiac arrests. Okay, trying to speed this up a bit. I realise we're probably a bit short of time. Brugada syndrome, it's a sodium channelopathy. It affects the sodium channel. It's associated with the same channel that causes type 3 lung QT syndrome. This was first described back in 1992 by the Brugada brothers. There's a very high incidence in Southeast Asia, where it was then called sudden unexplained nocturnal death syndrome. There are lots of other names. Can't remember them off the top of my head. Bangungut, I think, in the Philippines, and they've got specific names for this because it happens more than it should. It causes sudden death because of ventricular fibrillation, and people, as I've said, often die in their sleep or at rest. There are typical ECG patterns. They're not always spontaneous. Sometimes you can't see them and you have to unmask them. They can be unmasked sometimes by moving V1 and V2 of the chest leads on an ECG up to the first or second intercostal space, and sometimes that will bring out the pattern. You can do an adrenaline challenge, where you bring people into hospital and you give them the drug adrenaline, which will affect the conduction in the heart by affecting the sodium channels, and that might bring out the pattern. And sometimes it comes out in fever, which puts people more at risk. These are typical ECGs. Type 1 ECG, this is Cove ST7 with the inverted T wave. And this is what we see. I remember seeing this years ago before I'd heard of Brugada syndrome as a staff nurse on a coronary care unit, and a young person in the 20s coming in with these ECG patterns, and we're thinking, has he infarcted? Type 2 has this saddleback ST elevation, and type 3 has this kind of raised ST segment with a little hump in it. Type 1 is diagnostic, this cold pattern, and the other two are not necessarily so. But if you see these two types of ECGs, it is recommended in the literature that I've read that perhaps you should try and unmask type 1 by moving the ECG leads up, or by doing an adrenaline challenge. Genotyping, genetic testing for Brugada syndrome is very complicated. It's not easy to do, and we're not very good at it. Whereas with lung QT, if we genotype, we might find a pathogenic variant or a variant of uncertain significance, which may unravel later on. In about half of families with Brugada syndrome, I think looking at my results of testing that we've done in the last couple of years, we had about a 30% positive test. So it's not always the answer. You can't always advise people on the basis of genetic testing. Very often we just don't find anything. Phenotype correlations are really important when you're trying to work out whether somebody is going to be affected by this. So if you do have a genotype, if you have managed to identify a pathogenic variant associated with Brugada syndrome, usually in the SCN5A gene, sometimes there are other gene alterations, if we could do all the testing, added onto that make it more likely that people will collapse. So it's important to get as much information about family members as possible so that people can sit around a table and try and work out, which is where we're at the minute, whether or not we need to protect people with an ICD. It's really important to look at family history of sudden cardiac death, syncope. Do other people in the family have a Brugada pattern on the ECG, either spontaneously or is there evidence of that when they've had a fever? Does anybody in the family suffer from nocturnal agonal respiration, which might be a sign that they're having an arrhythmia? You might want to consider referring them for electrophysiological studies. Can these ventricular arrhythmias be induced in somebody who has a Brugada pattern? I'm sure that Neil will talk about this a bit more later on, so I'm not going to go into any detail with that. And ICDs are considered. It's recommended that these people have expert management with people who are experts in inherited cardiac conditions. And as I've already said, quite often the clinical decisions are made around a table or these days over a computer with an ICC MDT. People are more at risk of arrhythmia if they have Brugada pattern ECGs, if they have a fever. I don't know, quite honestly, what the physiology is there. Maybe Neil will be able to help us with it later. But we always advise people that if they have a fever, they should treat it. You should take regular paracetamol and ibuprofen if it's not contraindicated in them, and try and keep the fever at bay. We will often say to families, bring your kids in, come back to the hospital and get an ECG carried out if you've got a fever, because we're looking to see, does the ECG change when they have a fever. We also give advice about avoiding drugs which can affect the ECG if you have Brugada, and there are a list of drugs available on the brugadadrugs.org. Electrolyte imbalances, rehydration salts are important, and again, avoiding excess alcohol and recreational drugs. CPVT is catecholaminergic polymorphic VT, which is also an inherited disorder. This is the type of disorder that's horrible. It often presents and usually presents actually in very young people and often in children. Emotional factors or exercise. So when their adrenaline is high, it can induce syncope. It can cause palpitations and dizziness. Sometimes epilepsy is diagnosed because they're having seizures due to reflexonoxic seizures. The mean age of presentation is 6 to 10 years, but we think that it might also be implicated in sudden infant death syndrome. Sometimes people don't present until they're a bit older, but even with these people, when you look back and talk to them, it may well be that they've been having either absences or some sort of dizziness or palpitations before. About 75% of people with CPVT will be symptomatic before the age of 20. Nadolol is the beta blocker of choice with cardiologists to try and reduce the risk of arrhythmia. And ICDs are considered with beta blockers to reduce the risk of arrhythmia, and then an ICD is a backup plan for people who have had cardiac arrests or people who have documented syncope with VT, sustained VT. It's careful assessment and genotyping, and it should be done by somebody who's an expert in this. Sometimes thoracic sympathectomy is used if beta blockade is ineffective. And I'm sure if anybody's got any questions, Neil will be able to answer them. It's not something I'm familiar with. This is a typical polymorphic VT ECG that is seen in catecholaminergic polymorphic VT. It does exactly what it says on the tin. It looks a bit chaotic and it can deteriorate into VF. This is a family that I think you looked after a couple of years ago, last year actually. Young lad who was a twin, and he had frequent episodes of collapse during exercise and also in normal situations. These episodes last typically 20 to 30 seconds, but sometimes up to 3 minutes. He had spontaneous recovery after all of these episodes, but with a slight lethargy afterwards for a while. It was thought initially to be epilepsy, and he was started on sodium valproate, but this didn't help. He had a normal EEG, and he was referred to cardiology. His ECG at clinic showed inappropriate bradycardia and prolonged QT interval, so he was admitted with a suspicion that this might be a long QT. While he was in hospital, he collapsed, and he had a 72 ambulatory take on at the time, and this showed episodes of polymorphic VT. Subsequently, he was re-diagnosed with CPVT. He had a pacemaker inserted for the inappropriate bradycardia, and he was commenced on Nadolol to reduce the tachycardias. Genotyping was carried out, but those of you who've gone through that exercise know it takes about 6 months to get the result back. But when it came back, it confirmed that John had a pathogenic variant in the RYR2 gene, which is typical for people with CPVT. So his clinical diagnosis was confirmed genetically. That allowed us to carry out genetic testing on his brother and on his parents. They all underwent predictive testing and they came back as normal. This proved that his mutation was a de novo mutation, so it was unique to him. It was great for the rest of the family, and now he's getting the appropriate treatment. The other one that I had on the list was progressive cardiac conduction defect, or sometimes known as Lenegris syndrome. This one is something that I've only really got, I suppose, come into my sphere of knowledge in the last 2 or 3 years. Before that, it wasn't something that people were ever referred to the ICC clinic for. It was seen by general cardiologists. It causes bradycardias, heart block, sometimes tachycardias. Some of them are inappropriate. It's an inherited disease, which has an autosomal dominant inheritance. Sometimes it's associated with structural heart disease, but sometimes the heart is structurally normal, and it's just an electrical disease. We know that it's genetic because there have been lots of studies carried out, and they've looked at parents of pediatric patients who've had conduction alterations in the past and found that they also have conduction defects. So it shows there's a high heritability, and it can be caused by lots of different genes, genes encoding the cardiac ion channels, genes encoding proteins which interact with the ion channels, and cardiac transcription factors and cytoskeletal elements. So it's quite a complicated thing. It's something that is just now starting to come to the ICC-MDT, and we're just starting to put it into the sphere of knowledge. So I think it's rare, according to the literature, but I couldn't find a prevalence or an incidence. I suspect it's not as rare as we think. It's just it wasn't in the literature when most of the literature was published. And I think it's something that we should be more aware of. Sometimes these conduction defects that are seen in children and in young adults turn out later on to be associated with a structural heart problem like a cardiomyopathy. And I know that that's anecdotal, but I see that sometimes in clinic. It's just something to be aware of. Okay, I've probably gone over my time, so I'm going to stop there. I think the main message from me is think genetics. You might be the only one who does. You might put the pieces together. Don't worry about the specifics of it and the science of it. Refer them into either the Centre for Life if you think it is a definite genetic problem. Refer the families to the cardiac genetics clinics, the cardiac family history service, or refer to, if it's pediatrics, up to Neil Seller at the Freeman, or if it's an adult, somebody post 16 or 18, send them down to either James Cook or up to Freeman to see one of the adult EP guys. Right, thank you very much. That's all I have to say. I'm happy to take any questions either here or at the end, because I am aware that I've probably run over because there's a lot of information that I've done a whistle-stop tour of there. Thank you. Right, Kay, can you take over?
Yes, I can. Thanks so much. I'm just doing a quick questions. Terry, have you seen anything that I haven't seen?
No, there's no questions come through as yet.
Lovely, thank you. Excellent presentation. Julie, I really appreciate your input in today's webinar. Thank you so much.
My pleasure.
If you have the time and capacity, can you stick around for the end in case there's any questions?
Yeah, I will, definitely, no problem.
Much, Julie.
Thank you. Bye-bye.
Okay, so we're going to keep moving fast, and I'm going to introduce Dr. Neil Seller, who's our consultant paediatrician cardiologist at Freeman Hospital, and I'll let Neil introduce himself as he goes through. But he has added in a new Slido code, so he's loaded those questions onto a separate Slido account. So we're now using S for sugar 463. So Neil will make reference to that as he goes through his presentation. So he's just going to run some questions throughout his talk this morning. Neil, can you hear me?
Yes, I can. I was just muted.
Excellent. Thank you. So, without further ado, I'm going to hand you over to Neil. He's going to take you through the rest of the next hour and a bit of this morning. Thank you so much, Neil.
Right. Can everyone hear me?
We can, Neil, yes.
Okay, all right. So that's the first thing to do. And can everyone see the presentation?
Yes, Neil.
All right, and I don't know if you can see me on the camera. I'm just going to try and move my cat. She's my rescue, so I'm her favorite person.
Neil, just quite pixelated, but I'm getting a bit of feedback from the audience that this the whole
Pixelated.
thing is pixelated. But can anybody comment in the messages and just tell me?
Okay.
Okay, said connection was very bad, but it seems to have improved. So we'll look like it's settling down. Thank you so much.
Okay, so some people are saying it's fine. Some people, okay, all right. All right. So the first thing would be to just ask. This is more to kind of test the Slido code more than anything else. Okay, all right. Are we obviously seeing the results as they come in? So I'll just give that for a few seconds. It's kind of just, it helps me to kind of pitch the talk more than anything else. How many people have we got in total on the call, on the course, Kay?
About 45 at the moment.
Okay.
Yeah.
Right.
I think it's just jumped up actually. There's 57 there, Kay.
Okay.
We're getting about half of that response in poll, just so you've got an idea.
I'm kind of, I see that 17 people. Give it as soon as it stabilizes. Okay. All right, that seems to have stabilized. Well, okay, one straggler there. No, two more. Three more. I wonder if people are just getting the Slido code in and oh, so I see. Okay, Terry is actually entering some responses for us. Thank you very much for that. Okay, it seems to have kind of stabilized at that. All right, okay, that gives me a very good idea. And the next one, the nice thing about this is that obviously it's anonymous. So if you could just tell me how would you rate your confidence at interpreting an ECG? Because that'll obviously also help me pitch the talk. Okay. All right. We're 21 people again. So it seems like this is basically what people think an ECG looks like. If I go back to that slide. So hopefully we'll be able to change that today. So the question was just, the first thing that I looked at last night is how good are non-cardiologists at interpreting pediatric ECGs? So if you look at pediatric trainees, they're about 40 to 70% accurate, depending on their seniority. The first two studies is a US study. And when I speak about sensitivity, it means that how good people are actually at diagnosing an ECG as being abnormal. All right. So in other words, the lower the number, it means that the more false positives they've got. In other words, they're kind of over-diagnosing things. And then the specificity is how good are they at actually identifying an ECG that's normal. So you can see the first one, 75% sensitivity, 98% specificity. The next one is a Canadian study. This would be a Canadian study. And then the last one is actually a UK study. I'm just going to change my pointer that it's a little bit easier to see. It's a UK study where they cite an accuracy of about 61 to 73%. So 70% average, I would say. If you ask me, I think my cardiology colleagues are not much better. They'd probably be quite angry at me for saying that. But yeah, I'll slag them off continuously about that. But there are certainly some things that I think would be important to not miss on an ECG. So the way that I plan to do this talk, I didn't want to go down the normal route of doing the waves and the intervals and all of that first. So I'm going to skip this bit first, because I think we can get back to it. So the way that I wanted to do it is actually to kind of think of why are children referred to us as cardiologists, what the most common reasons are, and then does an ECG actually help you to make or to exclude a cardiac diagnosis or to make a cardiac diagnosis. And as you can see over here, that the vast majority of referrals to a pediatric cardiac center would be for a cardiac murmur. And then the next would be the palpitation, syncope, chest pain kind of wedge. Patients with, let's say, Down syndrome or another non-cardiac anomaly where the patients are usually referred for screening would be down there. Family history, certainly in the lines of things that Julie had mentioned earlier, also patients with bicuspid aortic valve or Marfan syndrome, those kind of things would fall in there. Other would be non-central cyanosis, Kawasaki disease, endocarditis referral checks, that had fallen there. So if we go through all of these sections, and then just look at how the ECG can help us to kind of try and weed out the potential diagnoses in these patients, I thought that would be much more useful. So the first one would be the murmurs, and there's basically a list of references here, and they all come to the same conclusion, that if you were to kind of clinically evaluate a patient and then do an ECG and a chest X-ray, in all cases in these studies, the ECG didn't actually change the diagnosis. So for the most part, I think that if you've decided something is abnormal, the ECG is not going to help you. And I don't, to be honest, we don't diagnose structural heart disease in children on the basis of ECGs alone anymore. Bottom line is most of those patients get an echo. Whether all patients with murmurs should be getting an echo is a different question. But certainly I think that if a patient is referred for an assessment of a murmur, I don't find ECGs very useful. So that kind of takes out a big chunk out of the presentations or of the potential presentations already. And the next one would be chest pain. And this is where I have got another question for the audience. So if you were to kind of just enter your response as to what you think the percentage of pediatric patients presenting with chest pain, what percentage of them actually has a cardiac cause for their chest pain? And this one I've kept it hidden. I don't know why. I didn't want people to influence each other. Okay, so we've got, I beg your pardon?
Less than 1%.
You think less than 1%, okay. So there are 24 people there. All right, so let's see. We got 25 people. Right. So the majority of you are wrong. Okay. The correct answer is 0.6%. Now, I mean, obviously an ECG can be helpful to kind of help exclude a cardiac cause, but for the most part, these children have got non-cardiac causes for their chest pain. And if we look at the particular causes, musculoskeletal pain, the vast majority of them, asthma and wheezing kind of related things, 12% of them, localized infection, 8%, gastrointestinal, obviously in areas where patients with sickle cell disease are more frequent, you find sickle cell disease as being one of them. If you look at the cardiac causes, arrhythmias causing chest discomfort, the most common, pericarditis next, myocarditis there as well. Strangely enough, myocardial infarctions, and this population, that population is probably the teenage amphetamine and cocaine abuse. And in this pulmonary embolism is probably more associated with patients on oral contraceptives. So not common, but certainly something that does occur. So what I have is I have some ECGs of patients that presented with chest pain. Now, the Q&A for Slido should be active. That's if I can just get it to open up. So if you guys would just potentially kind of give me an indication of what you think the potential pathology is on this ECG. I just want to check that everyone can see my presentation. Can everyone still see the ECG?
We can, yes.
Okay. Now I'm just trying to actually find the Slido screen where I so I'm going to get to my Slido administrative screen. I can see what you guys have been responding, what your responses are. So if you just give me a moment to log in, and
Neil, there's quite a lot of people having a guess in the chat box, if you can see that.
so I'm just okay. So if I go to the chat box in Teams, yeah, that's probably a good idea in any case. So right, so we've got a question mark. We've got some inverted T waves in the inferolateral leads. We've got anomalous coronary artery. We've got inverted T's and deep Q's. Okay, right. So what we have is, and obviously, I mean, the ECG, I think the secret to this is doing it systematically. Obviously, yes, there are normal values that one has to know, but one has to approach things systematically. Now, firstly, rate and rhythm. This patient, the heart rate is 150 beats a minute. The rhythm, it's difficult to see the P waves in the kind of normal limb leads over here. And perhaps in the chat, people can let me know if there any kind of terms that I use that they don't understand. So please just let me know. But in the normal limb leads over here, I can't see the P waves very clearly, but at least I can see them over here. So my assumption is that that's probably arising from a normal spot. If I look at the QRS complexes, they don't appear wide, but there are some Q waves that I don't expect to be there. I mean, specifically V6, V5, 1, AVL. There's in V4 as well. The other thing that I see is the ST segments. They appear relatively normal, but the T waves, they should be upright in these leads, and they're not. So they're inverted there, they're inverted in this inferior leads as well, they're inverted in these high lateral leads. So you've got T wave inversion, kind of diffuse T wave inversion. You've got Q waves all over. Now, some people had made a comment about anomalous coronary arteries. I'll get to that one a little bit later. But I think if I look at the responses, people have said hypertrophic cardiomyopathy. So the thing is, what's against hypertrophic cardiomyopathy is that we don't actually have kind of massive voltage criteria for left ventricular hypertrophy on this one. Someone had mentioned right ventricular hypertrophy cap pattern. Obviously depends on the age of the patient, but if I look at this ratio of the positive to the negative component in this patient, negative component is still larger, so I wouldn't necessarily have said that. Inverted T waves in the inferolateral leads, I agree with that. I think it's just a little bit more wider spread than that. Deep Qs, anomalous origin of the coronary, I said I'd come back to that. Inverted T waves, yeah, another hokum, we'll get back to that one. Long QT, no. But bottom line is that this is a rather nebulous one to start with. What we've got is we've got diffuse Q waves, we've got T waves all over, and this is actually myocarditis. This is kind of how non-specific a myocarditis can look. Bottom line is what you see is STT changes, Q waves, and they don't necessarily follow a specific pattern. And as I mentioned, I'll come back to the HOCM ECG, and I'll come back to the anomalous coronary artery ECG. So this is kind of what I wanted to mention over here, is that just as part of the detail, the T wave is generated on the ECG after the ventricle is depolarized. So it's kind of the recovery phase after the depolarization. And for people that aren't as confident about this, is that the T wave is usually this wave that follows the QRS complex. And you can have kind of examples of a normal looking T wave. Usually the descending limb is a little bit steeper than the ascending limb, can be peaked, it can be inverted, different inverted version, can be biphasic, can have a little notch in it, it can be flat. Hello? People here still hear me?
Yes, I can still hear you. I can just hear a phone.
No, so that, yeah, and then there was something that wrong with the internet, my internet here for a moment, so it seems to have sorted itself out.
Still here.
Okay, all right. So those are kind of different T waves that we can see, and this is in a way that it's kind of leading up to this slide as well. So this is also this is a 10-year-old boy with an autoimmune disease that presented with chest pain. So if people would like to comment on this one, I'd like to know what you think about this one. All right, so I'm getting pericarditis, ST segments that are elevated and prominent, ST elevation, pericarditis, ST elevation. All right. So I think everyone so far is correct. I mean, you can see prominent ST elevation, and once again, it's diffuse. It's all over. It's in the inferior leads, in the lateral leads. Peak tall T waves, yes, I agree with that as well. All right. The other thing that's typical for pericarditis is if you look at this little segment here, the PR segment, and if you look at the preceding TP segment, the TP segment actually represents the isoelectric line. That little PR segment is depressed. Usually in AVR, you find that it's elevated. It's kind of a reciprocal kind of finding. There might be some other leads where you can see the PR depression. I mean, V4, I can see it. V5, I can see it as well. That PR depression is actually the equivalent of the T wave of the atria that for some reason in pericarditis becomes more prominent. So this is a typical pericarditis, a fully evolved pericarditis kind of picture with ST segment elevation, widespread ST segment elevation, T wave kind of peaked. You can see kind of almost symmetrical T waves at points, and then PR depression. So this would be a very, very typical kind of ECG of that. Right. This is another one. So could people kind of just comment on what they think about this one? Okay. So I've got some high uptake saddle type ST segments. I've got tall peak T waves. I've got ST elevation. All right. Would anyone kind of warrant a guess as to what the diagnosis is here? Someone has said the myocardial infarction or anomalous left coronary artery from the pulmonary artery. We can get to that one again. Someone said myocardial infarction again. I'm kind of impressed because pediatric practitioners are really not that good at actually identifying ischemic changes. But this child is a 8-year-old child, had an ablation for Wolff-Parkinson-White and had a coronary artery injury. And what you can see over here is you can see these ST segments up here. You've got inferior ST segments, but with reciprocal ST depression. I mean, the high lateral ST segments are elevated as well. You've got Q waves starting to form. We don't have T wave inversion yet. So this represents transmural myocardial infarction. So very good. I mean, I think people had actually recognized ischemic changes. So those ST segments, I mean, we can have elevated ST segments, we can have depressed ST segments. So these are clearly abnormal. So what I find useful is this kind of approach to chest pain. And it basically tells you, I mean, for most of these patients, they will have at least a physical examination and a history. And then depending on the findings on history and physical examination, one might decide to actually do some further investigations, i.e. ECG or not. But I think what happens is that there's certainly some conditions that one don't want to miss, like the myocardial infarction, like the pericarditis kind of thing, that could potentially be easily recognized in an ECG. So the next big referral group would be patients with syncope. And 15% of children would have syncope at a point before their 18th birthday. So it's reasonably common. And we're talking about up to 75% of them would be typical vasovagal syncope. So what I've done here is I've listed all the potential causes. As you can see, it's a long list. It's a long list, and obviously one would be concerned about these cardiac ones because there are some nasty diagnoses in there. If you're talking about hypertrophic cardiomyopathy, left ventricular outflow tract obstruction, obviously some of the arrhythmias, some of the inherited cardiac conditions that Juliet mentioned earlier, all of those ones. So they're potentially nasty ones. So what the goal of the evaluation would be to try and see if an ECG or your investigations would help you in weeding out potential causes over here. So this one is a 15-year-old athlete that collapsed on a sports field. Would anyone like to warrant a guess as to what the diagnosis is here? Okay, we've got one suggestion of long QT. So we've got left ventricular hypertrophy, we've got right ventricular hypertrophy, right ventricular outflow tract obstruction, we've got Wolff-Parkinson-White, we've got someone mentioning ischemia, someone mentioning hypertrophic cardiomyopathy. So we've got a number of potential diagnoses here. Okay, right. So I think this would be a good one to go through. And actually, I think this one would be a good one to go back to some of the basics. Particularly this picture. So firstly, I mean, if just for some of the basics, for some people that aren't as confident, we've got different waves, and they're obviously generated by different parts of the heart depolarizing. The P wave represents the depolarization phase of the we've got this picture here. The P wave represents the depolarization phase of the atria. Then there's a little bit between the P wave and the QRS complex, which represents the conduction down the conduction system. Then we've got the QRS complex, which represents the depolarization of the ventricles. And then you've got this little recovery phase, like I've mentioned earlier, which is the T wave, and back to the start again. Now, The detail is not important, but obviously depending on, because we always measure electricity by measuring a voltage at 2 points. We don't measure a voltage just at 1 point. So we measure a voltage between two electrodes or between an electrode and a reference electrode. And depending on the way the electricity travels, you can have positive waves, you can have negative waves. But obviously the mass of the tissue that generates the electricity, the bigger the mass of the tissue, the larger the voltage it would generate. And for standardization purposes, people put ECGs on specific spots so that we can actually interpret and almost compare ECGs. Now, the important one over here is why we put the precordial leads around the chest like this. And what I want to emphasize is that V1 is closer to the right ventricle, and V6 is actually closer to the left ventricle. I mean, V1 is closer to the right ventricle than the left ventricle, and V6 closer to the left than it would be to the right. And that's an important thing to recognize, that V1 almost sees the right ventricle and V6 sees the left ventricle too. Sees the left ventricle mostly. And that's this thing that can help us diagnose chamber enlargement. And if we were to look at this one specifically, I would see that V6, the voltage in V6, almost reaches the baseline of V5. Now that's a kind of a quick and dirty trick. I mean, if it reaches up to V5, then it's the voltage that it's generated, the voltage that electrode sees is actually much higher than what you would usually expect. And seeing that the left ventricle sits right below V6, if you've got this large deflection in V6, that means that the electricity is traveling towards V6. That means that it actually represents the left ventricle depolarizing. This bit that we see going away from V1 would mean that it actually represents that bit of the left ventricle that depolarizes away from V1 towards V6. So it actually doesn't represent the right ventricle at all. Well, I mean, this one, I don't see much of the right ventricle because I would expect the right ventricle to actually have a positive deflection there. Also, the patient's T wave is positive because one would expect that at this age, 15-year-old, that T wave would be positive already. The other thing that you can see is that you can see that there are little Q waves in V6 over there. You can also see the fact that the T waves are inverted over here. And T waves should not be inverted in these leads at all. You've got T waves inverted in these inferior leads as well. And what this represents is basically, given the history of a 15-year-old athlete collapsing, one and with kind of this left ventricular hypertrophy pattern, one would be very, very concerned about hypertrophic cardiomyopathy in this kind of patient. So this would be one of those diagnoses where an ECG in a syncope patient would be quite helpful, and one of these diagnoses that one wouldn't want to miss, because if we think of the commonest cause for sudden death, sudden unexpected death, it is still hypertrophic cardiomyopathy. More. So this one is one that's thankfully not very common, but would anyone want to kind of just hazard a guess at what's going on here? So got deep Q waves. Yes, the patient has got deep Q waves and these inferior leads. it's not Q waves in children. Certainly in neonates can be up to 8 millimeters. So this would be more than you would expect. So certainly in V6 as well, there's some Q waves. The salient feature is actually the fact that if you were to look at this prominent P waves, yes, I've just had two people say prominent P waves. So this is massively peaked P waves, very, very negative P waves of a year. So the P wave, if you remember, P wave represents depolarization of the atria. And if the P wave is larger, it means that the mass of the atrium is larger. In other words, it must be hypertrophied. So a condition that can give you as large P waves like this, and obviously seems to affect the ventricles as well, is a condition called restrictive cardiomyopathy, where the ventricle is stiff. It's stiff, and that means that the atria have to work against massively high pressures to get their blood into the ventricle. And obviously these patients, they can have a limited cardiac output because the ventricles being stiff and not being able to fill properly. So they can have syncope as well. So yes, I mean, I've got people saying peaked P wave, P pulmonale, right atrial enlargement, all of that's correct. I mean, if we were to go, and I think if we were to go and formally measure this P wave, it would seem that it might be a little bit wide as well. So a wide P wave would be a feature of left atrial enlargement, and a peaked P wave would be a feature of right atrial enlargement. And I've just reminded me that I think I learned something in med school where one of the female colleagues had said that if you've got a wide P wave and it makes an M pattern, so that'd be like Madonna, and it means that that's P mitrale, so it's a left atrial enlargement, and very peaked waves like Dolly Parton, seeing that she's got very peaked or ample bosoms, that would also represent a P pulmonale, so a right atrial enlargement. So that's just one way that I certainly still remember from medical school days. What did I want to do? Yeah. I need to remind myself of this one. So this can everyone still see the presentation?
Can see you on the presentation.
Okay, so I think I just stumped myself here by pressing escape. So, okay, let me just get this presentation back up and running. So let me just get back to that point, because okay, I think we should be back. We should be back. Can everyone see my presentation now?
Not yet.
Good. Okay. All right. So now I just had to remind myself about this one. So, okay.
Neil?
Yes.
Not yet. Sorry, I've got a mask on. Not yet.
Not yet. Okay.
Not yet.
Let me just see what the issue is. Let me just click this button again. Can you see it now?
Yes, it's back.
Brilliant. Okay, all right. So I just had to remind myself what I wanted to say about this one. And in the meantime, I've got a lot of people saying yes, yes, yes. And before that, P pulmonale. So this is also this is a 5-year-old patient that presented with syncope. So what we've got is patients saying, I've got someone saying Epstein's anomaly, tricuspid atresia. So tricuspid atresia classically has a left axis deviation, so that wouldn't necessarily fit in here. People saying very peak P waves, I agree with that. Okay, if you look at this is a 5-year-old, and what we've got is we've got this massive right ventricle. We also have a left ventricle, all right, that's big. And I mean, obviously, what we've got as well is we've got the ST segments and the T waves being abnormal. But this child has massive pulmonary hypertension, and it's probably due to left-sided disease that they have pulmonary hypertension. So they've got biventricular hypertrophy. The point that I wanted to make is the fact that pulmonary hypertension, those patients, they can have a limited cardiac output as well, and they could have syncope. Now, someone has just mentioned Q waves and AVF. Actually, these are deep S waves. So they're not, oh, sorry, correction. There's certainly a deep Q wave and AVF. Yeah, you're correct, 100% correct. It must be that the septum of this patient is hypertrophied. I have to apologize. I was looking at the wrong lead. Yeah, so even I can look at the wrong leads at times. But the point about this one is that we've got pulmonary hypertension, we've got right ventricular hypertrophy, left ventricular hypertrophy. So obviously, seeing that those patients, the clinical features might be quite subtle. The ECG could have been helpful in this patient. So this is another one. This would be an 80-year-old chap that had a collapse, and an ECG was done. And would anyone want to warrant a guess? And I've got one correct answer already, I see. And I see the only answer is oh, I've got a few more. Okay, I've got 4 correct answers already. Okay, so to everyone that's answered delta wave or Wolff-Parkinson-White, 100% correct. So if I can just go through this, if I look at, I mean, any of the leads actually showed quite nicely. I've got a P wave, so the atrium depolarizes. And if we were to remind ourselves of that picture that I had earlier, and I mentioned that there's a little bit where it's flat before the QRS starts. Now that little bit where it's flat, and I'm just going to change the pointer again. That little bit where it's supposed to be, no. That little bit where it's supposed to be flat, in this case, we see that there's almost as if the QRS starts. It's almost as if the P wave immediately goes into the QRS complex. There's no little flat bit between the P wave and the QRS complex. And what this represents is that a bit of the ventricle is being depolarized ahead of the main bulk of the ventricle. And we call this pre-excitation. And this is due to, I mean, what people have called this is a delta wave, because if you're Greek, you draw a capital D or capital delta as a little triangle. I'm not doing the greatest job over here. But that's why it's called a delta wave. So this represents earlier activation of the ventricle than through the normal conduction system. So it represents a extra conduction pathway. And what was interesting is that people actually deduced the pathophysiology of this in 1930. So well before we actually had echocardiography, well, they even had, I mean, histology of this. So they kind of deduced what was going on just on the basis of what they saw in the ECGs. And I don't think many people have got those kind of skills these days to actually deduce de novo these kind of phenomena. So this would represent Wolff-Parkinson-White pattern. Now, the thing about Wolff-Parkinson-White is the fact that, yes, we know it can cause supraventricular tachycardia, but in the adolescent age group, it can result in sudden death in 4 in 1,000 patients. So it can potentially be a malignant condition. And that's why these patients undergo a formal form of risk stratification. So here's another one. This would be a 16-year-old lass that fainted. So would anyone want to, I'm kind of just, all right, I've got one answer already. Okay, there's another answer. Another answer. Another answer. They're all correct so far. All right, so those people that have actually mentioned long QT, 100% correct. Does anyone want to kind of warrant what's going on with this atrial rhythm? Because it doesn't look 100% regular, does it? Okay, so there's one person that's mentioned AV dissociation, and I think that's a important point to just, I'm just going to get my stylus, important point to just note on. If you look at these P waves here, there's a P wave there, followed by a QRS. There's a P wave there, followed by a QRS. There's a P wave there, followed by a QRS. P wave there, QRS. P wave there. Now, what one needs to do is obviously have some way of having a caliper. So what I'm going to do is I'm just going to do this. No, that's not what I wanted to do either. So I'm doing this so that you can see if those P waves seem to be coming, they seem to not be completely regular. All right. And the person that mentioned AV dissociation, what I want them to focus on is that, let's have a look at this QRS complex, this QRS complex, this QRS complex. If one were to measure this distance from there to there, if you were to measure this and this, you would see that the interval between the two P waves is almost exactly the interval between the QRS complexes. So that would mean that there's evidence that this P wave certainly is linked to this QRS complex, and that P wave is linked to that QRS complex. So I don't see any evidence of AV dissociation over here. I actually see the fact that this P wave seems to be earlier than expected, and it's actually advanced this Q wave earlier, or this QRS complex earlier. The same applies with this one. You've got a P wave there. This one is, if we're going to compare this one seems a little bit earlier. This one seems a bit earlier than expected, which means that this QRS seems a bit earlier than expected. This P wave is then relatively on time with the previous one, bringing in the QRS, and then there's a delay before the next P wave. And then we have the QRS complex. So this actually, I see someone is saying there's a progressive prolongation. I don't think that that's necessarily the case, that we've got this progressive prolongation, because I think they might be kind of pointing towards this bunch over here. Usually what we find in this kind of progressive prolongation of the PR interval and a Wenckebach phenomenon is the fact that the largest increment is at the first beat. And actually, I don't think that that's the case over here. What's the case over here is the fact that this patient actually has a normal physiological phenomenon, although in her, it seems to be a little bit more prominent, where you have a waxing and a waning of the atrial rate, where it slows down in expiration, speeds up in inspiration, speed up there in inspiration, slow down in expiration. So she's manifesting sinus arrhythmia, but rightly so, and certainly the best leads to usually measure this in would be V5. Rightly so, she's got a very, very prolonged QT interval. And obviously this is one of the arrhythmias that Julie had mentioned earlier, that can result in torsade de poids, and it's potentially a lethal condition. And I think I'm going to skip this one because I want to get to this one. This is the point that I want to make on this ECG is, once again, this is an example of a patient with an extremely prolonged QT interval. I mean, look at that. All right. Also, the morphology of the T wave is not normal. All right. We've got this ST segment, and then you've got a T wave that's almost symmetrical. Whereas if I showed you the normal T wave earlier on, it has a faster downsloping limb and a kind of a slower rising limb. This one, the ST segment, and then you've got a kind of a symmetrical T wave going on. But the next day, his ECG looked like this. All right. Now, I still don't think that these T waves are normal. They're very flat right throughout the recording. But you'd be hard pressed to convince me that this QT interval is the same as this one. And it just shows you the dynamics of the QT interval in these patients, and in all patients as such, and that a single ECG is not necessarily enough to exclude this diagnosis. And therefore, if a patient has recurrent syncope, certainly if there's a family history or something like that, or if they've got these very situational bounded syncopal events like exercise-induced syncope, or certainly if they've been swimming and they had a syncopal event, or if it had been with stress, or recent example that I've had is that a young lady had a fight, not a physical fight, she had an argument with one of the school friends, and during the argument she collapsed. So I think one just has to be vigilant that these patients are out there, and that your ECG might not be typical the first time you do it. So I just had a question. I see, and I'm trying to access it, but I seem to.
I can read it for you, Neil, if you like.
Please do, because I seem to have lost it.
Did the ECG change as drug was withdrawn, or does arrhythmia correct
That
it?
is a very, very good question. All right. So no. Firstly, it wasn't drug induced. No. So you can have this dynamicity in a patient's QT with proven long QT. They've got genetically proven long QT, and they can have QTs that varies by 50 milliseconds from time to time. So no, this was not the case that the patient had medication, so that they didn't have an acquired long QT syndrome. No. But also another point is the fact that beta blockers do not change your QT interval. It does not normalize your QT interval. All it does is it smooths your heart rate variability. And by doing that, it reduces the risk of you having a sudden change in your heart rate, which would be the precipitant for these dangerous arrhythmias. So my patients with long QT syndrome on beta blockers, their QT intervals are sometimes significant, 500, 550 still on beta blockers. So the beta blockers do not shorten your QT interval. So that's the other important thing. So this is from the same article, and I can certainly make the reference available with regards to evaluation of syncope that I've also found quite useful, certainly with regards to deciding which patients would require further evaluation or not, particularly with regards to these red flags at the side of here. So now, before I get to the rhythms, I was going to talk about other conditions or other reasons why patients can be referred and why an ECG might be useful. So a child might have a non-cardiac condition, or the child might be evaluated for something else, and when you do the chest x-ray, you find, oh, the heart's big. Or obviously patients with family history of certain conditions, they get referred to us, and then the ECG can help, like the long QT syndromes, certainly not necessarily with Marfan syndrome or bicuspid aortic valve, but long QT syndrome and Brugada syndrome and those ones. So this is an 8-month-old infant with hypotonia. That's had an ECG, not because of any abnormalities, any kind of rhythm or such abnormalities, but they just had an ECG. So would anyone want to warrant a guess as to any abnormalities that they see on this ECG? All right, we've got one answer already. And someone just kind of shot from the hip and had the right answer, so that's very good. Okay, I think that's a reasonable, someone had kind of mentioned hypertrophic cardiomyopathy. That's a reasonable suggestion. Another hypertrophic cardiomyopathy, people are mentioning T-wave inversion, biventricular hypertrophy. They're not seeing P waves. I think they are P waves. The reason why he's not seeing a P wave is for a very, very specific reason. We've got another positive T-wave in AVR. Yeah, okay. I think that question, that point was mentioned earlier, and the reason why it's positive, it's probably reciprocal from it's a mirror image kind of, it's mirroring other leads. Now, one person had the right answer right off the bat. Although hypertrophic cardiomyopathy, in essence, this is probably a form of hypertrophic cardiomyopathy. So if we go back and we see V6, looking at the left ventricle, I mean, you see very, very large QRS complexes. So very large QRS complexes. V1, you also see very large QRS complexes. So certainly, yes, biventricular hypertrophy, this patient's got both their ventricle enlarged. They've got T waves that are inverted and look funny. So that myocardium certainly is not normal. I completely agree with that. The other thing is that the one person mentioned that fact that they saw that they didn't see P waves. I think you're finding difficulty to see P wave because the P wave is right next to the QRS complex. So for some reason, there's very rapid conduction from the P wave from the atria to the ventricle. Very rapid conduction, but it's not pre-excited like we saw the delta waves in other patients. So this would be a typical, and if you see these, I mean, you see these large QRS complexes in all the leads. I mean, everything looks massive. So this is a typical ECG for a patient with Pompey's disease. So glycogen storage disease, because of the glycogen storage in the myocardial cells, you've got this rapid conduction, kind of much faster than what you would find usually. So the PR interval is shortened, and then obviously there's just massive voltages that's being generated. Strangely enough, in this patient, you've got this phenomenon where the QRS changes, the voltage changes on alternate beats, which is something that you sometimes see in patients with pericardial effusions, if they've got tamponade, pneumothoraces, and I mean, sometimes we see it in some of the arrhythmias as well. So this patient's got that interesting phenomenon going on as well. But the point of this is that 8-month-old hypotonia, you basically made the diagnosis with the ECG. This is a kind of a gestalt diagnosis, just looking at the ECG. So very good to the person that got that right off the bat there. Right. What did I want to say about this one? Yes. Okay. This is a 5-month-old, and he came in kind of respiratory tract infection, not well, and he's got a big heart in the chest X-ray. So any kind of comments as to abnormal findings on the ECG? So we've got someone saying right ventricular hypertrophy. Yeah, okay, I can buy that. ST elevation and right ventricular hypertrophy. Yeah, it's kind of, beg your pardon? Sorry, I hear someone. So we've got kind of a elevation of the J point over here. The T waves, they don't look completely normal. I agree. Okay. But what's striking would be these Q waves. Okay. So these striking Q waves. So that would be the one thing. All right. I just want to kind of get back to, so that's the one thing. We've got striking Q waves. Striking Q waves, we've got ST segment changes, and I have to say that I have to apologize. This is not a 5-month-old. This is actually, this is probably a 5-year-old boy with some weakness. The next one is the 5-month-old. So that does change things. So yes, the 8 millimeter up to 8 millimeter of a Q wave in the inferior leads, that would be in the neonatal group. Yes. So so I just have to backtrack a little bit. So this is probably a 5-year-old boy, and he's been evaluated. And if I say the next thing, I'm going to give the game away completely. He's been evaluated for muscle weakness. And I have to apologize. I put you guys on a fool's errand over there for a moment. So yeah, so there's suddenly, I mean, as soon as I said that, then obviously the penny dropped. So this is a patient with muscular dystrophy, Duchenne's muscular dystrophy, which can have kind of Q waves, and they can have conduction tissue disease as well. Yes, low voltage in V6. So their kind of progression of their R waves is not completely normal. You can see, so that basically it just means that the muscle of the ventricle is abnormal. So this is the 5-month-old that came in with a big heart in the chest X-ray. And apologies once again, for the confusion that I caused. So we've got someone saying that this is supraventricular tachycardia. If it is a supraventricular tachycardia, then, I mean, I see discrete P waves, so then it must be a kind of atrial tachycardia going on. Someone says ST elevation. Yeah, I can see ST elevation in C5 and this V5 and V6. 1 AVL. Okay. Think biventricular hypertrophy. I don't think we've got voltage criteria for left ventricular hypertrophy, possibly for right ventricular hypertrophy. 5 minutes call, seriously. What I want to focus on is deep Q waves. Deep Q waves in 1 and AVL. What time did I start, Kay?
Hiya.
What time did I start?
25 past.
25 past.
Oh, no, you want before that.
Huh?
Hang on. You were...
Not what time I was due to start. What time did I start?
Well, we've got until 12:30. And we still need to do the live sim and the debrief, so...
But the live sim and the debrief has to happen in that up until 12:30.
Yeah.
All right. Okay. All right. I'll just have to hurry up then. So L kappa. Someone said L kappa. So yeah. Anomalous left coronary artery from the pulmonary artery. And this is typical. This deep Q wave in 1 and AVL. And obviously you can have Q waves in V5 and V6 as well. But you've got ST segment elevation there. So this is also a diagnosis that you can make on an ECG. And so you've got X-ray, baby's got a big heart, ECG, diagnosis made. And this is one of those reversible cardiomyopathies. I'm going to skip this one. Actually going to have to run through a number of these slides because I want to get to this. So one of the reasons why patients are often referred to us would be for an irregular heart rhythm. So this is an ECG of one of those patients having been referred in. She's this one is an 8-year-old girl. Otherwise well. She just had been seen for a routine visit, and when they did her pulse, they thought that her heart rate was irregular. And there's one answer already. There's 2 answers. I think the one's correct, the other one's not correct. Okay. The issue. So let's just go through this one. They need a long lead too. There's a long lead too down here. So let's just see. Okay, so if I describe a rhythm, the first thing that I do is I look at, is it regular or is it irregular? Now, this is clearly not regular. Okay. And then I try and see if there's any kind of regularity to the irregularity. So is there a pattern? And I don't clearly see a pattern. All that I see is that these three are kind of grouped in a way. These three are grouped in a way. So then I try and figure out, because the next thing that's important is, are there P waves? And are all the P waves, do all the P waves look the same? So if I just follow this one, there's a P wave, there's a P wave, there's a P wave, there's a P wave, there's one, there's one, there's one, there's one, there's one. Okay, they're P waves and they look the same. And then I look at each P wave followed by a QRS. So has each P wave got a partner? So it looks like each P wave has a partner. All right. So if I try and figure this out and say, but okay, does this P wave, then if this was the rate at what the sinus node was depolarizing, I would expect the next P wave to be there. So which means that this P wave is delayed. And then this one, compared to this interval, is a little bit earlier. This one is on time. Then this one is delayed. Then this one is kind of the same time, kind of expected time, earlier. So it seems like it's slowing down and accelerating and slowing down and accelerating and slowing down and accelerating. And young people, this can be quite profound. You can have a 10% sway in the beat-to-beat kind of cycle length. So this would be sinus arrhythmia. And obviously, this is a completely normal physiological phenomenon, and it doesn't require any intervention or any further investigation. Why is my presentation? All right. So this is another one of a young chap that was referred because of an irregular heart rhythm. For the sake of time, I'm just going to go through this one. So what I see is that it certainly looks irregular, and it looks like these QRS complexes don't look the same. This one looks different to this one. This one looks different to this one. So what I've got is I've got two different QRS complexes, and if I look at this one, this QRS complex, it doesn't seem like there's a P wave in front of it. So this QRS complex almost arises on its own. So this would be an example of what I would say underlying sinus rhythm. So sinus rhythm with frequent ventricular ectopic beats or premature ventricular complexes or premature ventricular beats. There's some controversy in the literature with regards to the exact terminology, but I don't think that's necessarily important. But what this shows is that we've got a normal beat, a premature ventricular beat, a little pause, a compensatory pause that we've got over there. And then we've got PVC, oh, sorry, normal beat, PVC or premature ventricular complex again. And this is another reason why someone can have an irregular heart rhythm. Usually if this is frequent, then we tend to investigate the children for, well, certainly keep them under review in the case of patients with structurally normal hearts, because frequent ventricular ectopic beats can potentially lead to a cardiomyopathy. This can be the primary cause of a cardiomyopathy. So in those patients, we certainly would consider even ablating these foci if necessary. This one is someone that was referred due to irregular heart rhythm. And when they did the ECG, you can also see that, and this is particularly this highlights the fact that don't rely just on one lead, because if you look at this lead, this beat doesn't look particularly abnormal. One would almost say that this is the abnormal beat just at first glance. But if you look at these top beats, then you realize, hey, these ones are actually wider than expected. And we don't see a P wave in front of them. So what this patient has is then sinus rhythm with ventricular ectopic beats alternating with the normal beats, and that's got a specific name called PVCs and bigeminy. So this one, something we see occasionally, something, I mean, this is actually a little neonate that was referred to us. You can see, I mean, still relatively large ventricles. So it's what you expect in a neonate. The axis is rightwards. What you can see is that the rhythm mostly looks regular, but every now and again, there's something that kind of disturbs it. So it's regular, kind of regular all along here. And then suddenly this one seems to be a little bit earlier than expected. And then it seems like 2 beats have come normally and then earlier than expected. And the same applies here. So this patient has actually got what frequent supraventricular or premature atrial beats. So sinus rhythm with frequent supraventricular beats. And for the most part, these patients don't need any, I mean, you probably should see them in a month after birth, and that by that stage, most of them have actually settled. So we will see an example of this shortly. Well, not example of this, but an example of a child with a rapid heart rate. And the most common reason why patients get referred to us for rapid heart rates would still be sinus tachycardia. And this is just an example of sinus tachycardia where the patient has a fever and they've got a physiological sinus tachycardia. Just trying to get my Teams open again. Yeah, there it is. So questions, people are asking what is frequent. So it depends on how you measure it and what you're recording it with. If you're recording it with an ambulatory ECG, anything more than 1% would be considered frequent, more than 1%, or alternatively, if it happens more than 10 times a minute. So 10 times a minute would be anything more than one PVC on a 12-lead screen would be considered frequent, because that means that it's twice in 10 seconds. So that's what I would kind of consider as being frequent. So this, just to go through this, like I mean, it's a very rapid heart rate. We're talking about almost 300 beats a minute. All the QRS complexes look the same. It's very regular. All the QRS complexes are narrow. And if I were to try and actually look for P waves, I'd find it very, very difficult to see P waves in this. I think these little bumps over there are probably T waves. But I'd be very, very difficult to convince myself either way. So this would be a form of a regular narrow complex tachycardia. And obviously we'll see an example of that shortly. This is another form of a narrow complex tachycardia where you actually see P waves. You can see the P wave there just in front of these QRS complexes. And the P wave is negative in these 3 leads, which would be completely abnormal for P wave appearance. So this is another version of supraventricular tachycardia. This is another one where this is a slightly older child, regular narrow complex tachycardia, and I don't see any P waves anywhere. So this is another version of a supraventricular tachycardia. This is a little infant that had intrauterine tachycardia. And when the ECG was done after birth, I want you guys to focus on specifically this lead here. And yes, I've got one correct answer kind of coming floating through already. This is a neonate with atrial flutter. And the thing to remember with this is that if they've got structurally normal hearts, if we cardiovert these patients, they might never require any further therapy for this. So this would be an example of neonatal atrial flutter. And then we see these from time to time. And so I just as a final kind of ECG, because I think I'm encroaching on the time. So someone's saying ventricular tachycardia, someone's saying right bundle branch block. You're both correct. So this is not, so what we can see over here is that the point about this ECG is the fact that the default diagnosis should be ventricular tachycardia. Our default diagnosis should not be supraventricular, that is a supraventricular rhythm. We should say this is ventricular tachycardia until we've proven otherwise. And there are a few things on this ECG that actually absolutely proves that it is ventricular tachycardia. The fact that we've got P wave dissociation over here. So there's a P wave, but I don't see any other P waves in front of the QRSs as such. There's a P wave holding on the shoulder of the T wave there. I glanced across it, and there's another one there. So these P waves aren't associated with this QRS complexes at all. Also, the QRS complex is wide. So it's a wide complex tachycardia, correct, but it's a very, very specific wide complex tachycardia. It's got a right bundle branch morphology, and the axis is different. So this one would be one of these idiopathic left ventricular tachycardia. So the patients can have structurally normal hearts. It's a very typical kind of ECG presentation. But the point about this ECG is that wide complex tachycardia is ventricular tachycardia until we've proven otherwise. I mean, I've got more examples, and I think what I can do is that these other examples that I've got left, I think people would be able to go through them on their own, because I think we should get on with a case presentation. So, Kay, that would probably be the conclusion for me. And because obviously the simulation or the case presentation must still take place.
I'm sorry, short. I know to give you next time. Thank you so much.
No, it's a pleasure.
Will you stick around for the
Certainly. Certainly.
So I just need to move into the next room and get set up in there. Your screen will change in a few moments to see the live screen. So if anybody wants a quick comfort break, we'll then just press straight on and get ourselves sorted. So I'll see you over in the other room in just a moment. Thank you. Hello everybody and welcome back. I really hope you can hear me. I'll speak nice and clear, as will my colleagues Katie and Sarah. I'd like to introduce you to our scenario, and this is live in the ED department. We've moved into resus, a baby who is 4.8 kilos, who is 2 months old. No previous history, no antenatal or postnatal diagnosis, nothing untoward with this baby. Mum's been concerned about him over the last 24 hours, just not taking his feeds, quite irritable. And then today, she, the early part of this morning, after not taking his feeds, she undressed him and she just described sort of a bounding chest wall, fast heart rate. She can feel his chest when she's trying to console him and cuddle him in. So as I said, we brought him into ED, resus, and we'll work through our sim and we'll see you at the debrief. Thank you.
It's not a great colour, Sarah. I'll put some oxygen on. While I do, will you put some ECG dots on for me? I'll just start with my assessment. So we are self-ventilating at 15 litres of oxygen. We have a respiratory rate of around about in the mid-30s. With minimal increased work breathing, cardiovascular is currently entered with a peripheral clear refill of 5 seconds and a central cap refill of about 3 seconds. Heart rate is very fast, but we're in SVT at the moment, so can we get a hand, please?
Hiya, okay, I'm the pediatrician on for today. What's going on?
I've got a 2-month-old baby that is in SVT at the moment. I just needed some help.
Okay.
We're looking at the stable side of the algorithm because he is self-ventilating and he does look okay.
Okay.
So we just need some advice and some help, please.
Yeah, absolutely. So, can we do a blood pressure, please? So, yeah, can't see any obvious P waves. Probably the ECG on for simulation purposes. Saturating well. Stable at present. So, can we get some ice and we'll try 30-second ice to the face, please? And just continuous structured assessment throughout Katie, please. Sarah, can you get some IV access for this baby, please? And moment, she just doing circulation. Okay. Okay. So let me know when you've got that IV access in, Sarah. Around 30 seconds on the ice.
30 seconds done.
Okay,
Is there a shutdown if I can't get this in? Can I use an IO?
Yes, if we move into sort of unstable, that would be very useful, but not if we're thinking about adenosine, doesn't get to the heart quick enough. So give me a go with that IV, and if not, I'll give it a try myself, Sarah. Okay, we're in. Fantastic, thank you. So we've got IV access. Ice hasn't really worked with this baby. We'll not go with vagal manoeuvres. We'll just move on. We'll try some adenosine. So can we get adenosine ready with a 3-way tap, Sarah, for fast administration? We'll go 100 mics for the first dose.
That's 100 mics of adenosine, which is 480 mics.
Yeah. Okay. So 4.8 kilos, 100 mics. So we're going to give fast administration, Sarah. Can you just let me know when that's in?
Okay, so a 3-way tap, large flush. Happy?
Yeah, adenosine.
Adenosine in, flush in. Okay, so we'll just give that a couple of minutes. Katie, any change in the baby's assessment?
No change, still the same.
Okay, so it doesn't look like that had. Sarah, can you get a 200 mics per kilo dose ready, please? We'll just give that another. So that's 200 mics per kilo of adenosine, that's 960 mics. So 3 way tap again. Katie, can you just run another blood pressure as well, please?
Yeah.
Large, just hold on there, Sarah. When you're ready. Just get a blood pressure. Alright, that's around 2 minutes there. Just get that blood pressure on.
We've got emergency equipment as well ready, haven't we?
Okay, so we've got an emergency trolley in the room.
Yeah.
Yeah, and then
Got resource drugs,
lovely.
intubation drugs should we need them, and some fluids as well.
Okay, still stable at present.
Yeah,
Blood pressure's
still.
fine. Okay, we'll go with that second dose, 200 mics per kilo, Sarah.
Adenosine in, saline flush in.
That's in. Okay, looks like we've got it. Give that a minute. That looks much better. Sinus rhythm. About 135-ish, saturating well. Can we run another blood pressure, please? And Katie, can you do another full assessment, please?
Yeah, so self-ventilating at 15 litres. Respiratory wise has got a respiratory rate around mid-30s with minimal increased work of breathing. Saturations are in the mid-90s.
Excellent.
Cardiovascularly has now got a capillary refill time peripherally of 3 seconds and centrally of 2 seconds. Heart rate's down to 135 and I've recycled the blood pressure come up to 2.
Excellent.
Visibility wise is alert and is getting mad at me.
Fantastic, fantastic. Well, it looks like we're back in sinus rhythm, stable at present. We'll keep putting for observation for a little while. I'll pop back, I'll go and chat with Mum, just tell her to talk possibly about a cardiology referral and see if there's anything going on with this baby. And thank you very much, excellent work. Thanks, guys.
Thank you.
Hello, welcome back everybody. So Neil, could you come on camera please, and Julie, could you also come on camera if appropriate, thank you. Questions. Welcome. Thank you very much. I hope everybody managed to see that and it was good enough quality. We'll obviously get some feedback on that. I'm going to try and speak over the mask, so I do hope you can hear me. So we'll start by saying, what do you think went well?
I think we recognised SVT very quickly. I think we got help very quickly. I think we communicated really well and worked well as a team.
Yeah, it seemed to be quite calm and under control. Does that sort of give you some reassurance when you're thinking stable part of the pathway, and would that have made a difference had we have been on the unstable sort of elements of the pathway?
Yeah, definitely. I think we were quite lucky actually that the patient was stable. Katie obviously did a full 8-day assessment, responded appropriately. We had some oxygen on, and actually he was stable enough to go down to the stable algorithm in terms of treating his SVT. So it was a bit of reassurance actually that he was stable.
So we made reference to some of the emergency equipment. Obviously it's in a resus, but what kind of things sort of would give you that reassurance should the patient's condition change at any point?
I think we know with SVT that things can change very quickly. So we had our resus trolley in there in case we needed to proceed to manage the airway for the child. We had a defib in case we needed to move to cardioversion, and then we also had some fluid and some intubation drugs and some resuscitation drugs should we need them drawn up ready on top of the resus trolley.
Excellent. So throughout the sim, I'll bring you in, Neil, here. So throughout the simulation, we did 100 mics, then 200 mics. Obviously, we have a third dose available to us. What would be the course of treatment after that, and what would we advise sort of with regards to cardioversion?
So, I mean, obviously, if the patient's unstable, I would go as quickly as I can to cardioversion. I would, if usually, obviously, it takes time to obtain AV access and time to actually draw up the drugs and stuff like that. And if the patient's unwell and unstable, I wouldn't necessarily waste time there. With regards to the adenosine, so frequently people comment that the adenosine didn't work. So it might be interpreted as the fact that your first dosage didn't work, but actually it did, because it did briefly terminate the tachycardia. Unfortunately, it was just not a sustained effect. And sometimes when you give a second dosage, it certainly does terminate the tachycardia. It's probably not because the adenosine sticks around for a little bit longer. It's just probably we kind of lucky at that stage. Usually, if I find that if a patient like that, that's otherwise stable, if they have failed 2 or 3 dosages of adenosine, at that stage, I would request that obviously pediatric cardiology be consulted, because at that stage, I would usually recommend that the patient be given, if the patient's stable, I would actually recommend that they be given a dosage of a beta blocker to just control the heart rate at least. Often it does terminate the tachycardia, but it means that we've got a little bit of time to be able to kind of get the patient to us to assess the patient. I know that the APLS says amiodarone, consider amiodarone. I would advise against that, partly because it makes my evaluation and management of the patient a little bit more difficult, because if the patient's been loaded up with amiodarone, it makes it very difficult to give them any other medicines during that stage. And certainly, I would think that for the stable patient, we have less, well, we've got options available with better side effect profiles to give at that stage. So I would prefer that. And with regards to if the patient becomes unstable, then yes, then amiodarone would be a consideration. Now, I see that there's a question there regarding if the patient needs to be intubated and shocked or just shocked. I mean, obviously, if the patient's unwell, I would proceed with normal resuscitation. So intubation at that stage is almost invariably required. If you're doing an elective cardioversion, often you are able to have the patient just sedated or kind of sedated for the cardioversion, and they don't necessarily have to be intubated. But in these cases where you do an emergent cardioversion, you're almost invariably going to intubate the patient as well. And then you might be lucky that with intubation that causes a vagal response, and it might terminate the tachycardia for you as well. I've certainly seen that happen as well.
Thank you, that's great. Just going back to the adenosine administration, Sarah, you used a specific sort of technique, and I know that's certainly in the NECTA guideline. Is that quite a fiddly technique? Is that something that you need to practice?
It probably is worth practicing. I'm very experienced in using 3-way taps because I've used them for a number of years now. However, I think it is worth at least having a look at one, knowing where your arrows are pointing and making sure that you're actually open. The trick with adenosine is it has to be given very quickly, and you need a very, very large flush. So it does require having a 3-way tap on there, and it must be administered in that way. Which is why I actually had everything ready there in the tray. So as soon as I had IV access, I could attach the 3-way tap, and depending on what route we went down, at least we had that there ready.
Excellent, thank you. There's a question on the chat, Neil, that I'd like you to respond to about IO access.
So IO access for fluids, and obviously some medications is fine. Adenosine, the problem is that you're not going to get the adenosine because the adenosine needs to go into the coronary arteries as such. So you need to get, and the problem is that it gets metabolized probably within seconds. So if you inject it into the interosseous space, into the medullary cavity, it's going to kind of seep through medullary cavity and then has to make its way back out of the bone into the systemic circulation, and by that stage, it's been metabolized. So it doesn't work giving it intraosseous, but obviously other medications do. So if one needs to give interosseous access for resuscitative purposes and potentially having to give medicines, then that would be appropriate, but certainly not for adenosine administration.
Excellent answer, thank you. So just to sort of round up, because I think we've covered it really well throughout the debrief, is there anything else that you think you could have done differently, any different approach, any feedback from the audience? I know there's a couple of comments around sort of dunking the infant in cold water, icy cold water, and we've certainly seen that done. And yeah, I guess one of the things to raise was just sort of knowing where that ice is and how accessible that is within your regions, within your departments.
I think that's really important. So every place has a different way of obtaining ice. And where I work, we have these bags that we have in the freezer ready. Not everywhere has those. We have used an ice machine before. So it's really important that you know where you can get ice from.
Katie's experience?
We went to Costa.
Costa Coffee. Costa. So yeah, amazing.
Brilliant, brilliant.
How you can adapt to a situation should you need to. So is there anything else anybody else would like to add to the debrief? Anything you think that no?
I think the only thing we said was we were lucky that this patient was stable, but it's really important to have your resus equipment there ready.
Yeah,
these children can become very unstable at any point during that. If everything's there ready, we always hope that it won't be needed.
Sorry, can I ask one question? So you got your access on the dorsum of the hand. Did you not try on the cubital fossa because it is more near to the heart?
No.
In terms of access, sorry.
Yeah. You just that wasn't a.
I've just put in my first cannula.
Yes.
It is the recommendation, yes, that you have to be close to the heart. But if you've got a good enough vessel, if you've got a good enough vein that you can actually give a good enough chaser afterwards, it should be all right most of the time.
Thank you.
Thank you. A little bit of feedback from one of our participants. Just saying, next time, can we please include cardioversion simulations? If that's something that would be interesting, I will do not necessarily a live one, but I'll pre-record a cardioversion simulation if you think that would be useful, and I'll get that out on the network website.
Okay, next time we do one, if we've got any kind of warning, maybe we can record one where we actually do a real life one.
Okay, well, the way things are going, Neil, with the future of telecommunication, I think we'll definitely be doing that real time.
No, but it's good to have one to kind of have one on file then, for educational purposes. Yeah.
Yeah, but in the meantime, we'll do. I'll certainly get that recorded for you and put onto the network website. That's no problem at all. So once again, I would just like to thank every single one of our panel and participants today, and a huge thank you to the audience for your participation. It could have gone very differently had you not have been as interactive as you have been. So thank you so much for joining us in these crazy, unprecedented times. I appreciate you taking the time to join us today in your very, very busy work lives. So without further ado, thank you everybody, and we look forward to seeing you soon. The presentations and the videos will be on our network website really soon, so keep an eye out. Thanks so much. Anything you want in the future, just send me a line, drop me an email, let me know and we'll get that sorted for you. Thanks a lot. Have a good day.
Bye.
Fantastic weekend.
Bye-bye.
Bye-bye. Sit tight. Oh well. No, we're still.